Hello, everyone. Thank you for joining us for this installment of the Root Cause Coalition's 2018 How-To webinar series. Before we get started, I want to run through a few features of our webinar today. All of our attendees will be in listen-only mode for the duration of the webinar. At the end of the webinar, our panelists will be answering audience questions. If you have a question during the webinar, please type your question into the question pane on the webinar control panel located at the right side of your screen. This webinar is being recorded and will be available for viewing on the Root Cause Coalition website later this week. Before we start, I want to extend a huge thank you to Siren, the Social Research and Evaluation Network, for co-hosting this month's How-To webinar series. Thank you all again for attending, and at this time, I'm going to turn it over to Caroline Fitchenberg from Siren to introduce our panelists.
Hello, everyone, and welcome. This is Caroline Fichtenberg. As Monique mentioned, I'm the Managing Director of Siren, the Social Interventions Research and Evaluation Network. Siren, for those of you who are not familiar with us, is a national research acceleration and dissemination initiative housed at UCSF that focuses on helping to build and disseminate evidence about how health systems can better address patients' social determinants of health. We are excited to co-host this webinar with the Root Cause Coalition. At Siren, we often hear from healthcare sites that are implementing interventions to address patients' social and economic needs and who want to evaluate their programs to know whether they're having the impact they want to have and to be able to document that impact for key stakeholders inside and outside their organizations. So we're really happy today to be showcasing the work of two leading physician researchers who have done important work in this area. We're going to hear first from Dr. Seth Berkowitz, an assistant professor of medicine in the Division of General Medicine and Clinical Epidemiology at the University of California School of Medicine. Dr. Berkowitz will be giving an overview of evaluation strategies for social needs interventions with examples from his and others' work. We'll next hear from Dr. Danielle Cullen, a pediatric emergency medicine physician at the Children's Hospital of Philadelphia. Dr. Cullen will describe how she implemented a randomized control trial to identify the most effective ways to screen patients for food insecurity in the ED setting. As a reminder, if you have questions during the presentation, please enter them in the chat box on the right-hand side of your screen, and we will be answering those questions at the end of the two presentations. I will now turn it over to Dr. Berkowitz.
Okay. Great. Well, thanks very much, Caroline. Thanks to everyone for attending this call. Excited to talk with this group. As mentioned, I'm going to talk a little bit about some of the things I think about when trying to plan an evaluation and thinking about what strategy that we might use. I have no disclosures to report. And the sort of more specific goals that I wanted to go over today were the considerations around deciding to do an evaluation and then reviewing the pros and cons of some common strategies that are used for evaluation of social needs types interventions. The first question, is why do an evaluation? And I mean, in some sense, this seems very obvious. We want to know whether the programs that we're putting our resources into, that we're putting our time into, whether they're working. And I think that's right in a lot of ways, but whether something is working as we get a more specific definition of what it means to work can get complicated. And I think there are some actually important considerations about whether to even do an evaluation in the first place. The first thing that really needs to be thought about are the cost of doing an evaluation, and including the sort of time and opportunity cost. So not just the cost of running the program, but the things that would need to happen above and beyond the sort of normal day-to-day operations in order to do real evaluation. And that often is a not inconsiderable amount of effort and potentially extra resources to go in. And so I think we need to have a clear sense of what we want to get out of the evaluation to understand whether it's worth it to do that evaluation in the first place. In sort of going down the tree of deciding around these things, I think it's important to consider what is being evaluated. So are we looking to evaluate outcomes, either sort of clinical outcomes, did health as measured by some metric improve, or outcomes as they might relate to the other things in the space. So did food insecurity get better in a nutrition intervention? Did housing stability improve in a housing intervention? The other thing that you may think about trying to evaluate is sort of the process. So are we fulfilling the steps of the intervention? Are we kind of doing the things in the logic model that we expect to lead to something down the line? And the decision about evaluating outcomes, processes, or both includes a number of different factors. If there's really no prior existing evidence that an intervention of the type that you're doing works to improve health, then you really may want to study outcomes. You may want to see if this particular way to address food insecurity actually improves hemoglobin A1C in people with diabetes, for example. On the other hand, if you are trying to implement an intervention that's been proven elsewhere, it may be possible to get by just evaluating your process. So are you kind of doing the steps that have been shown in another setting to work? And if that's the case, it might be an easier evaluation to do. And since the link between that intervention and health has already been established externally, that might be fine. Similarly, if you're very early in the process and you're not even sure that this is the type of program that you want to fully commit to evaluating with outcomes yet, you want to just sort of make sure it works to hone and refine, then you really may want to focus more on the process of what's going on. So I think those considerations are really important when deciding whether to do an evaluation or not, and really thinking about what you're trying to get out of the information. Another thing to think about, so I'll just stop there in terms of thinking about, say, those are the main considerations around doing whether to do an evaluation or not. So now let's say that we've decided we do want to do an evaluation, and maybe in particular we're going to evaluate outcomes in this case, just as an example. Now we'll start thinking about, well, so what are some of the considerations when deciding on the strategy to use to do an evaluation? So a major one is going to be whether the data already exist or not. So if they already exist, what's sometimes called a retrospective evaluation, where you're sort of looking back over something that has already happened, that's a very different process than situations where you need to collect the data or look forward, or what's sometimes called a prospective evaluation. So that's a major branch point in deciding about what strategy to use. Another thing that is really important to think about is what's called power. So what is the size of an effect that we can detect? In general, to detect a smaller effect, you need more participants or more data of some sort, what's sometimes called the sample size. And so in general, to detect a smaller effect, that larger sample size will often come with a larger investment of resources. If you're doing a retrospective study, the sample size may be fixed. If you're using data that's already available, then you've got what you've got. And so it's really worth thinking about whether this is the kind of data set that can answer the question you want. So for example, if you think your intervention may, say, reduce hemoglobin A1C by 20% of its initial value, it's worth doing the calculations ahead of time and saying, hey, if we've got 100 patients, is that even plausible? Could we show that, or would it take many more than that to do it? On the flip side, if you're doing a prospective evaluation and you're in the same situation, you think your intervention will improve hemoglobin A1C by 20%, it's worth doing the calculations to say, all right, how many people do we need to recruit? Do we have the resources to do that? Say it's, it takes 500 people to do that or something like that. Can we plausibly recruit 500 people? So the power, the sample size, and the effect size are all really important to think about when deciding on a strategy. And then the last thing to think about is what's called the mechanism for treatment assignment. So how do people get the intervention? And the really big branch point here is whether that's going to be randomized in some fashion or not. And I'll go into a little bit more about the randomization decision. So for randomized designs, the key aspect is that the assignment to the treatment occurs at random somehow, and I'll get into what I mean at somehow. The real reason to do this is that it guarantees a lack of confounding between the treatment and the outcome. And by confounding, I mean a common cause of the treatment and the outcome, something that would both cause someone to get treated and differentially experience the outcome. And when there is confounding, the association between the treatment and the outcome is not necessarily a causal association. And so our whole goal in doing these evaluations is to really say, all right, this intervention caused the outcome results that we're seeing. And when there's confounding, we can't be as confident at doing that. So all of our strategies are trying to minimize confounding in some way, and randomization is a really powerful way to reduce confounding. When I say treatment assignment has to occur at random somehow, that doesn't necessarily mean that an individual needs to be randomized. That's sort of the classic paradigm where, we flip a coin and person A gets the treatment and person B gets the control or something like that. That is one example of randomization, but it's not necessarily the entire story. And you can randomize things at different levels. So things like if you had a number of sites, you can randomize the site, the clinic, the food pantry site, et cetera, that gets a particular type of intervention. You potentially could randomize based on the person that someone is interacting with. Certain caseworkers do things one way and certain caseworkers do things another way, or the particular clinician. And things like that. So you can randomize different aspects of the treatment, but in any of them, the common feature is that we're trying to break the link between the characteristics of the individual and why they got the treatment. We want that to have occurred at random or under our control in some way. The other thing that I think is really important to mention with randomized interventions, particularly in this space, is that you don't have to withhold an intervention in part of the group to do randomization. So I think a lot of times people are worried that, all right, we're screening people for food insecurity and our study is going to be, try to address food insecurity versus don't do anything about it. And no one who's in, this line of work wants to do that, right? I mean, we're all here to help people. And it's really not necessary to design randomized studies where the alternative is not getting anything. You can compare different versions of treatments. You can, use wait lists, taking advantage of the fact that you might not be able to serve everybody all at once. So just to sort of put out there that randomization is not synonymous with withholding treatment from people, which is a concern that people often have. And just to sort of follow up on that, I think in almost all circumstances that we're in sort of social determinants interventions, there are rarely enough resources to provide the intervention to everyone who might need it. And that winds up, I think, being a powerful justification for randomization in many circumstances, because if you're not using randomization, you're just allocating the scarce resources in another potentially unfair way. Someone who signs up first, somebody who has the more proactive case manager, et cetera. So, so if you're already going to be limiting the resources or the treatment in some way due to resource scarcity, then randomization is often a way that lets you learn best from the programs. Some of the pros of randomized design, the main one is that when done well, it provides really strong evidence of causality because you're taking care of that confounding that I was talking about before. And then as I was alluding to in the last slide, I think it can be in some circumstances a fair allocation of scarce resources as opposed to someone just getting into a program because they know the right people or something like that. As cons, randomized studies are often relatively more expensive because there's sort of a bigger evaluation framework and infrastructure that's needed to support them. They can be time consuming. Depending on the circumstance that you're working in, there may be more regulatory oversight, although I caution, I was divided as to whether to put this as a con. It may require more effort, but I think this regulatory oversight is really important. It protects both the participants and it also protects the investigators as well when you're sort of doing everything by the book and having a third party look into the practices and make sure that it's protecting the participants, and you subsequently as an investigator are protected at the same time by having this third party to kind of take a look into things. So potentially a con in terms of effort, but I don't mean con in any kind of pejorative way for this one. And then the last thing I'll mention is, though randomization protects about confounding at baseline, if people are lost to follow-up in differential ways across the group, so if the intervention group all completes the study and the control group drops out or something like that, then you can still have some confounding there, even though there wasn't confounding due to baseline factors. So still, it doesn't the randomization doesn't get rid of all possibility of confounding, but it's a really good start. And just as an example, I pulled this study from a couple of silent network investigators, And there's a citation here if you want to look into it a little more, but just to show you that it is certainly possible and very doable to approach these kinds of intervention in a randomized way. And I think part of the reason that this study had so much impact was because it was a randomized design, and so what the conclusions we could draw from it were very strong. So now I'll get into some non-randomized designs. So these are any situation in my mind where treatment assignment does not occur at random. And so when that happens, what we need to do a rigorous evaluation is carefully construct a control group to account for this confounding, to try to minimize it as well as possible. We've already said the treatment assignment is no longer under the control of the investigators. That's what puts us in the non-randomized space. But we need to sort of make use of either the data that's available or the data that we choose to collect in order to try to make these groups as comparable as possible. And a huge amount of the effort in designing a non-randomized study goes into trying to think about how to make the comparison group as comparable as possible. The sort of a busy slide, but I just wanted to list out the types of considerations on data that you might need in order to really do this well. So first is data on the treatment assignment mechanism. How is it that people get into treatment? Who are the people who get treated versus who don't? How do the people who are enrolling people in programs or deciding who gets treated or who even come in seeking treatment, how does that happen? The next two related things are, it's great, it's really necessary to have data on what happened to the treated group after they get the treatment of whatever kind, and data on the treatment group prior to the treatment of any kind. If you could only have one, after is probably what you get, but by having both, you really are enabling yourself to look at a trend over time, and that becomes a much more powerful thing. So ideally, you'd love to see a hemoglobin A1C in sort of our running example before someone got their food insecurity intervention and after their food insecurity intervention, and even more ideal would be a couple hemoglobin A1Cs before and a couple hemoglobin A1Cs after. And then similarly, in the comparison group, you ideally would want data both prior to treatment and after treatment. So again, you could really look at the trend that would happen in both the groups. So I've sort of characterized the next couple sections into what I'm calling stronger or weaker designs. There are definitely overlaps between all of these, and there are situations where what I'm saying here may not fully apply, but I think this is a somewhat useful way to think about this. So in general, I think a stronger non-randomized design has data on both the treatment and the comparison or control group before and after treatment. So if you get all of those things, then I think you're in a good space. If you get only some of those elements, then I think you're in the space of a weaker design. So say you get data on the treated group that is before and after treatment, but you don't have a comparison group. This is sometimes called a pre-post study, or sometimes can be done in the terms of an interrupted time series analysis or something like that. I think this is relatively weaker than if you had more data. It doesn't necessarily mean we can't learn anything from it or that it's not a useful design in some circumstances, but I think it's relatively weaker because in this case, you only have data on the treated group, but not a comparison group. Alternatively, you could get data on both the treated and a comparison group, but only after treatment. This is sometimes called a prevalent users design because it's looking at people who are when the decision to either use or not use has already been made, and sort of following what happens in that way. This again can certainly be okay, but you don't necessarily know what trajectory people were on before the treatment decision was made, and so you may not have as much confidence that you're really getting all the information that led to the treatment decision, since you don't really know what was going on beforehand. So of the stronger non-randomized design, these are the ones where you have data on both groups before and after treatment. You can, if the data is good, is it's a rich data source, and this really allows you to adjust for confounding well. If you've measured all the things that you think might lead some person to get treatment and some person not to, then you can account for confounding, and even though you didn't assign treatment at random, you can still have a better sense of what's going on. In this context, for individuals sort of serve as their own controls in some sense. So that's to say, if you have data on people before and after receiving treatment, there are certain unchanging factors of that person where the any effect that might have on the outcome balances or sort of washes out basically. So say you're studying a treatment and you think level of education is an important confounder. Maybe you think that people with lower educational attainment may do worse on this particular thing. Well, if you have a measurement both before and after the intervention, people's education level likely didn't change in the meantime, and so any change that you do see is more likely to be the treatment and less likely to be due to the level of education, since that didn't change. So that's a very useful property of having data before and after. As I mentioned before, you're able to estimate trajectory, particularly if you have a couple measurements. So, if you may see that someone's hemoglobin A1C went down after an intervention, but your question may be, well, was this already going down? Did the rate of change change, so to speak? If you only have one measurement or no measurements beforehand, you won't know this. But if you have, one measurement a year for the past couple years, and you saw it was 10 and then 9 and then 8, and after your intervention it went down to 6, you could say, well, that went down more than we would have expected based on the past trajectory. So that can be very useful. Also, these non-randomized designs are often cheaper than randomized designs because they often require less study infrastructure. Not as many people to do it, not necessarily as hard to enroll people. And if the data were already collected, then it's possibly faster to get the study done rather than waiting to do the study prospectively. So that's an advantage. As a con, there's always this concern about unmeasured confounding. No matter how much data that you have, you worry, well, did we miss some factor that may have led some people to get the treatment and others not to? So that's a concern. And especially if this is retrospective, if the data is already collected, it might not have been collected specifically for your purposes. So you may say, well, I wouldn't have done it exactly that way if I had been designing it, but it's already done now, and so you don't necessarily have control over that. So you might be not able to capture something that you would have wanted. As an example of this type of design, this is a study that I was involved in where we looked at the use of a medically tailored meal delivery program provided by Community Servings, an organization in Boston, to people who were members of Commonwealth Care Alliance, which is a healthcare organization that provides care for people with Medicare and Medicaid dual eligibles. So in this study, we looked at whether participating in this program was associated with reductions in healthcare costs. We used what I'm terming in this case one of the stronger quote-unquote designs, where we had data on people both before and after the intervention in both a treated and a matched control group. And the reason that we chose this was, A, the data was already there, so it was a lot faster and a lot less resource intense than trying to do a randomized trial or something like that. But B, because we were working in a claims data context, we did have information both before and after people started the intervention. So we felt like that was the best way to optimize the data that we had. Okay, so now just sort of wrap up by talking about some of the weaker, what I'm terming the weaker non-randomized designs. So in the pre-post study, this is the situation where you have data on a treated group both before and after, but you don't have a control group. This is often the least resource intense study because you're only dealing with sort of one group of people. If the data are already available, if it's retrospective, then it can be quite fast. And you do still get the advantage of individuals serving as their own controls for factors that don't change. So that's very useful. The cons here are it's really difficult to account for confounding because you don't have a comparison group, and so it's really hard to know why the people in your study got the treatment compared with other people because you don't have the other people to compare to. There's also this issue of regression to the mean, which is basically that if you're selecting people on the basis of some extreme value, you're selecting the people with the highest hemoglobin A1C or the most emergency department visits or the highest healthcare cost, it's very likely that in the next period you measure, their value will be less extreme, even if you didn't do anything. And the reason has to do with if there's some random variation in what people do, the people who sort of get above a cut point and are then artificially selected, that random variation over time is going to wash out, but you won't necessarily know what is just the random variation washing out versus the true effect of your intervention. It's easy to overinterpret an effect of the intervention to something that might have happened anyway. And when you have a control group that you select similarly, they also have very high utilization or a high A1C or something, you can see, all right, well, here's how much of the change is, just happens not because of any specific intervention, but just due to the washout of the random variation. But when you don't have a control group, you're not really able to estimate that effect, and so you can be fooled by this regression to the mean phenomenon. And then the last thing is what are sometimes called secular trends. So these are things that are sort of going on in society overall or in sort of the larger context that aren't specific to your intervention, but may still have an effect on the outcome. So if you're doing an intervention that's trying to control healthcare costs, but you're existing in a overall framework where more organizations are going to ACOs and implementing X, Y, and Z other cost containment measures, if you don't have a contemporaneous control group that's undergoing those same other things, then you won't know how much of any change that you see is due to your intervention versus just the stuff that's going on in the background. And then the last of these designs that I'm going to talk about is what I'm calling the sort of prevalent user non-randomized design. So this is when you start with people who are getting the treatment and then all of them going forward along with a comparison group. A major advantage of this is that you often have a lot more people to study because in any given case, if you have an intervention that's sustained over a long period of time, you're likely to have more people currently using the intervention than who start in any given year. So, say 100 new people start an intervention every year and only 10 people stop. At any given time, you're going to have a lot more people using the intervention currently than waiting to see, all right, let's collect the next 200 people who start. So you can often get a lot more people in these prevalent user designs. And again, especially if they're retrospective, they can be faster than a randomized design. The main issue here, though, is that there can be unmeasured confounding because you're starting once people already have gotten the intervention, and so you don't know too much about what was going on beforehand that might have let you determine why someone got the intervention versus not. So that's a major limitation. And unlike the sort of stronger designs that I was talking about before, where you can try to model the treatment assignment as best you can, you're sort of stuck in this case because you're coming in after the intervention has already started. As an example of this type of study, this is another one that I worked on where we looked at participation in SNAP, the Supplemental Nutrition Assistance Program. And so here we took people who were already on the SNAP program, compared them with people who were income eligible but not on the SNAP program and looked at their healthcare expenditures. We ideally would have liked to use an incident user design, so sort of followed people before they started on SNAP and afterwards, but we had forget the exact number, something like 2,000 people on SNAP who are prevalent users, and in the data set that we had, only like 300 or 400 who were incident users who actually started SNAP during the period that we were observing, and so it just wasn't feasible to do the study that way. We would have not been able to detect an effect of the size that we thought SNAP might cause. We would only have been able to detect a much bigger size, and so it really wouldn't have been a worthwhile study in that case. So we used the prevalent user design, tried to match people to non-users as best we could, but we had to acknowledge that without really knowing why people started on SNAP in the first place, there's a significant threat of unmeasured confounding. So just to wrap up before I turn it over, I think some summary points are for evaluation. You really want to consider carefully the need for evaluation. Why are you doing it? What are you hoping to get out of it? What will be the use of whatever the product of the evaluation is, whether it's a scientific paper or white paper or a report to a funder or your board or whatever else. If you're going to proceed, really commit to it and budget for it. I think too often, because almost everything in the social determinant space is often being done on a shoestring, and evaluation is no different. But if you're not really prioritizing it and budgeting for it, you're really limiting yourself in terms of what you can accomplish. And the worst is to get an equivocal evaluation, because then no matter whatever resources you put into it, you're not really getting much out of it, because at the end of the day, your evaluation wasn't able to say give you a definitive answer. And so, those resources were probably not well spent. So I think really committing to it and budgeting for it up front is very important. I think you should always choose the strongest feasible method. There are many circumstances in which a stronger method is not necessarily that much more work than a weaker method, but may require some upfront planning. So as an example, I once worked with an organization that was doing a screening program, and their plan was to screen people, keep records of the positive cases, people who screened positive, and then how they did in the intervention. And they were just planning on discarding all the negative screens because they said, well, we're not working with these folks, so why keep it? So when we talked, we said, well, let's keep the negative screens, and then we were able to turn it from a pre-post design to one that was really able to generate a strong comparison group because we had both the positive and negative screens. We could get data on both groups and compare people. That was really very minimal additional work at the setup. We literally just had a box that we maintained the negative screens in rather than shredding them. But it really led to a much stronger study because we're able to get that comparison group. And I think there are a lot of examples where by a little upfront planning, you can do a stronger study without too much extra effort. So that's the same point there, trying to plan up front. When feasible, I think randomizing is really a good bet. The quality of the evidence you get from it is really hard to beat. The people will believe your result a lot more. There's a lot of work that goes into it, and there are certain circumstances where it's just not feasible, but many times it is. And I think the cases where it's feasible are often more common than people initially expect. Again, you don't necessarily need to withhold treatments from people. You don't even necessarily need to do randomization at an individual level or things like that. So there are a lot of cases where it's feasible, and if it is feasible, I think that really makes a lot of sense. However, if it's not, and there are many cases that are not, and I gave you 2 examples of studies that I've done that were not randomized, you really want to spend a lot of time trying to pay attention to the construction of the comparison group. That's really going to be the heart of the study and the heart of learning something from the study. And then the last point is just that evaluation is a team sport. I think you really want to be soliciting input from folks with lots of different backgrounds, perspectives. You want people who have the expertise in evaluating and things like that, but you also want people with expertise in implementing the program. You want input from the participants in the program themselves. It's no use coming up with a really elegant ivory tower design if it's just not going to work on the ground. So you really want to kind of get all the different stakeholders in a room from the beginning to come up with a plan that will both generate strong evidence for your program, but be easy to implement in real life and really serve the needs of the people that you're trying to serve. So I think that is about it. And so now I'm going to turn it over to Danielle. My email's there for questions. All right, thanks.
All right. Hi, everyone. Thank you so much for participating in this webinar today and for having me be a part of it as well. I am going to build a little bit on what Seth was speaking about and give an example of a randomized control trial in social needs intervention. So this was a study on caregiver preferences for food insecurity screening. I have no disclosures. And what we're going to do today is I'll explain a little bit of a background about this study, why it is that we chose the design that we did, some of the ways in which we were framing the study in order to solicit buy-in, and then I'll breeze through the results and then go over some pearls just in what I've learned in developing social needs interventions as well as evaluating those. So I saw in many people's backgrounds that there is a lot of comfort around food insecurity, but for those of you who may not have background in it, food insecurity is the limited or uncertain availability of nutritionally adequate or safe foods. And it is a large and often under-recognized problem for children especially. In Philadelphia, we found that over 1 in every 5 kids struggles at some point with food insecurity. And this has lasting health consequences through childhood and into adulthood. Kids who are food insecure are 2 times more likely to be in poor overall health. They have more headaches, stomach aches, and even colds, more hospitalization days, developmental disabilities, and more chronic illness and poor management of those chronic illnesses. If there is anything good about food insecurity, it's that studying it can be an excellent proxy for some other social determinants of health. And the reason for that is because there are currently readily available resources both in the community as well as federally. There is a validated 2-question screening tool for food insecurity known as the Hunger Vital Sign with the questions that you see listed here. And along the way, there's been an increasing emphasis on addressing food insecurity specifically as a social determinant of health, especially in pediatrics. In 2013, the American Pediatric Association Task Force on Childhood Poverty, in their strategic roadmap, mentioned food insecurity and addressing social determinants of health as a major priority for the future of pediatrics. Similarly, the American Academy of Pediatrics in 2015 put out a policy statement recommending that all pediatricians in any clinical setting screen for food insecurity and try to address it to the best of their abilities. And more recently, the Center for Medicare and Medicaid Services put forward $157 million to create accountable health communities to address social determinants of health, and food insecurity is one of them. The challenge is that doing the right thing is not always easy. And in the clinical setting, there are multiple barriers to accurate responses when we do initiate screening for food insecurity and other social determinants. Once that screening is done and referrals are made, there are low participation in programs. And as an emergency medicine provider, frequently what people come to me with is the concern that this shouldn't be the ED or acute care settings role, and shouldn't we be focusing more on the management of these acute health issues. But what I know in seeing the patients that I do is that we serve as the front line for patients with higher social need who aren't necessarily getting to their primary care physicians all the time or as they should. And so the emergency department or acute care setting can be an excellent point of entry into care. So we designed this study specifically to figure out if the emergency department is a good setting, figure out what would be best for our patient population that we're serving in order to mitigate some of those barriers to accurate responses, and also get buy-in on the part of the healthcare system and the healthcare providers who aren't necessarily yet comfortable with screening and intervening. So our objectives were to estimate the prevalence of food insecurity in the emergency department, to compare a verbal versus a tablet-based screening modality in which would maximize our ability to detect social need as well as maximize caregiver or parent comfort with this, as well as to evaluate the preferences that caregivers have in modality and screening location. Our study setting was the Urban Pediatric Emergency Department of the Children's Hospital of Philadelphia. This ED sees over 99,000 visits annually. It serves as both the community hospital for West Philadelphia as well as a quaternary care referral center. We decided to do a randomized control trial with an explanatory sequential mixed method design, and I'll explain a little bit more about what that means. The reason for the randomized control trial is, as Seth was talking about, to get the most robust study design that we could, while really defining the process. And the process that we were looking to define is how to do the screening in order to maximize caregiver comfort, as well as minimize the burden on clinical care time, as well as the discomfort that providers were telling us that they had with this process. The explanatory sequential mixed method design means that in addition to this, we conducted 40 follow-up semi-structured interviews by phone in order to get more information from the families themselves about their experience with the screen in the emergency department, the experience with the resources after referral took place, if there had been any, why or why not to follow up, to start building on the information that we gained from that randomized portion. Patients in this design were randomized to identical verbal or tablet-based questionnaires that included the validated food insecurity screening questions that were mentioned before, that hunger vital sign, the caregiver's comfort with the food insecurity screen in the emergency department, as well as their expected level of comfort if that screen had taken place in their primary care office, as well as questions about their preferred screening modality. regardless of the answers that participants gave, because we did expect that some people would screen negative even if they did have experience with food insecurity, we gave all participants a list of food access resources. These resources were developed in conjunction with a local community agency, the Philadelphia Coalition Against Hunger, and that it was all based on what our patients had told us previously that they would be interested in as far as food resources. We also provided an option for direct connection to a referral agency where families who screened positive could provide their phone number and be contacted within the week by the Coalition Against Hunger to be directly connected with resources. As far as our study design, so this is what a flowchart might look like for a randomized control trial. We included patients that caregivers of patients that were under 18 years of age who presented to the ED in non-critical conditions, who were English speaking and not previously enrolled in the study. As Seth had mentioned before about power in the study, we made a calculation ahead of time determining that we needed at least 1,808 caregivers or participants in our study to be randomized in order to detect a 5% difference in rates of reported food insecurity between the verbal and tablet-based groups. So that was our goal sample size. We also selected ahead of time in order to enhance the robustness of our design. We selected 4-hour time periods, 7 days a week, that were all predefined for study enrollment, and we tried to get a consecutive sample within each of those timeframes, meaning that we were trying to enroll all patients that came into the ED during that 4-hour period in order to maximize our participation and make sure that our sample was representative of the ED patient population. Over a 6-month period, we found over 2,000 patients, you can see here, were eligible for the study. When approached, 130 of those had no caregiver present, so were omitted. And 204 caregivers that were approached refused, with the top 4 reasons of refusal being that they weren't interested, were too stressed out in the emergency department, were about to be discharged, or too tired and wanted to rest. Ultimately, we randomized 1,820 patients, with 910 to each arm of our study. 2 of our tablet-based surveys were left incomplete. We're not sure if this was a technical glitch or if these were intentionally left incomplete, but regardless, our loss to follow-up, as was mentioned before, wasn't significant. With any randomized control trial especially, but with any study, as Seth was mentioning again, you want to make sure that your control group or that your 2 study arms are comparable. So this is a typical table 1 where we're looking at patient age, race, ethnicity, and in this case, level of acuity of presentation to the ED, and we found no significant differences between the 2 groups. When we looked at screening modality, we did find that the tablet-based group had a significantly higher rate of reported food insecurity as compared to the verbal group, with a rate of 23.6% compared to 17.7% for the verbal group. When asking families about their preferred screening modality, of those who had a preference, which was about 1/3 of our patient population, our study sample, there was a significantly higher, over 80% preference for the tablet-based screen as opposed to the verbal-based screen. And this pattern was seen across both the populations that reported food insecurity as well as those who reported that they were not food insecure. In asking about screening location, there was a high level of comfort across the board with food insecurity screening. However, we did find a significantly higher level of reported comfort with an ED-based screen. And again, this pattern was seen across those reporting food insecurity and those who are not food insecure. When we looked into demographics of the population and if there was anything different between the food insecure the patients reporting food insecurity and those who are not food insecure, we found no significant differences between patient age. Among race, we found that that caregivers who reported that they were Black or African American had a higher rate of food insecurity, while those who identified as Asian or white had a lower rate of food insecurity. Those who identified as Hispanic or Latino, again, had a higher rate of food insecurity. And as far as level of acuity, this was something that we were able to do as our study was looking across all patients presenting to the emergency department. Although it has often been expected that patients who are presenting to the emergency department for less urgent complaints might have higher rates of social need, this was not what we found in our study. There was no difference across the levels of acuity from sickest to least sick on the emergency severity index between the patients who reported that they were food insecure or not food insecure. As I had mentioned before, in our study design, we allowed for an option for direct connection to a food resource agency in addition to providing paper-based referrals. And among the 375 participants who screened positive for food insecurity, 54% opted in to receive a direct connection. Among those, about 37% could be reached. And of those who were reached, there was an additional 31% who said that they were no longer interested in the resources that were available. For those who were reached and provided with resources, the majority were connected to a local food pantry or emergency food resource, and 11% were federally connected. And what I mean by this is that during the phone call with the resource agency, they were signed up for the Supplemental Nutrition Assistance Program, or SNAP. Our major takeaways from this study is that, and what we were able to present to the hospital system, is that our urban emergency department may have a higher rate of social risk compared to the general patient population, and that this would be a good place for screening. Not only was screening in the emergency department acceptable to families, but something inherent, we believe, to the anonymity of being a patient in the emergency department actually served as a protective factor and increased the level of comfort that patients had with screening in the emergency department. Tablet-based screening both maximized our ability to detect social risk, as well as served as the preferred method of screening among our caregiver population. And although, as we were mentioning before, although it's frequently expected that a targeted screening would be sufficient based on certain demographics, we found that instead there was no difference in level of acuity between the patients who reported food insecurity and not. So we would not recommend a targeted screening in just, let's say, the urgent care setting, but rather a universal screening and intervention protocol when one would be put in place. Before that, of course, as you saw, our study echoed what's been found in the literature as well, which is after that screening takes place and the referral is given, there is a significant drop-off in the connection with food resources or other social resources. And so we need to figure out that piece in order to create an effective intervention before we would fully recommend screening and intervention protocols. So our next steps, that qualitative component that I was talking about before, is currently under data analysis. So unfortunately, I don't have those results to share with you today, but will give us greater information about the experience with screening, the use of food assistance programs after referral, the usefulness of those programs, as well as caregiver preferences and resource connections. Overall, in defining the process and studying a social needs intervention, the major pearls that I've learned, and stepping back a little bit, is before something is integrated into the electronic medical record or into standard practice, what is very important is to involve your target population, making sure that we're not coming from a top-down perspective, thinking about what we think would be an effective intervention and putting that in place, but rather finding out what would be acceptable and feasible to our patient population in maximizing their benefit from these programs that we're looking to create. Second is allowing the process to be iterative. when we were doing our needs assessment ahead of time before the initiation of this project, we found that families were telling us that they felt uncomfortable with endorsing their social need in front of other people and even sometimes in front of their children. So changing the design of our study to make sure that all of the screening that we were doing and patient recruitment that we were doing was in individual patient rooms was something that was important to our study design. Also allowing for variations in patient care and patient flow, and building the process around that was something that was important to our design development as well. Considering sustainability, we know from speaking with providers in our emergency department that there is concern with patient flow, with burnout, with not interfering patient care with an additional screening protocol. So as much as we possibly could, we took the role of the provider out of this social needs intervention and the screening. Reason for that being that if we were to design an intervention that would be initiated and universalized, we would want it to be something that would be able to be feasible and stick around and sustainable and that people would actually use. So thinking about that in all of the processes. And lastly, developing partnerships and listening closely. So partnering with community agencies was huge for us, and considering in all of those partnerships, what are the difficulties that the community agencies have? What are the difficulties that the healthcare system has? And how can we each play on each other's strengths to make sure that we're designing something that will address those needs, address those concerns, make sure that we're not overwhelming capacity, and allowing each partner to be an integral part of the design and development of our intervention. So again, thank you so much for having me. I'm looking forward to any questions, and please feel free to reach out.
Thank you so much to both of our presenters, Seth and Danielle. At this time, I just want to remind our participants, if you have a question from the presentations, feel free to please insert your question, take your question out into the question pane on the webinar control panel, usually located at the right side of your screen. We have a lot of questions so far, so I'm really excited to talk with our two panelists. But in the meantime, while our participants are asking questions, Danielle, you just talked about those pearls of interventions and how it involves, how we need to involve the target population really at the outset when we're creating these interventions. And it reminds me of one of these values that the Root Cause Coalition holds really dear, is this idea that we need to work with community rather than at them. And so I'm wondering if you have seen in your work any best practices for engaging and involving that target population really at the outset.
Thank you for that question. Absolutely, I agree with that tenet that Root Cause Coalition has. And as far as best practices, what I can say from my own personal experience, not necessarily from the I suppose from the community-based participatory research literature, but as healthcare providers and from the healthcare organization, we can often sit on our ivory tower and think of the way that we want things to be done. But as we're identifying and defining problems in the community, it's best to identify somebody in the community who can advise you and tell you actually what's happening, not just in what your perspective is occurring. So something that I found very helpful is in talking with our community partners and finding out what are the difficulties for them. What would be processes that they would undertake, or what changes would they make in systems if they could? And similarly, in trying to find patients, for me coming from healthcare, that would be willing to share their experiences and their struggles through the process as well. That way we're building something together. I think that the more that you can involve community agencies and community members in the design of a social intervention, the better.
Great, thank you so much, Danielle. And this question is for either you, Danielle, or Seth, but one of our participants asked what your opinions are on using secondary data at the state and county levels, et cetera, as a substitute for recruiting and measuring a control group. And to further that question, is this applicable in a population with a large socioeconomic diverse population?
I can try to speak to that a little bit along with, I'm sure, Danielle. So I think it really, I don't think there's a straightforward yes or no answer there. I think it really comes down to what data do you need to do the study well. And so, if the data that you need to help find the right comparison group is already available in a secondary data source, then that's great, and there's no reason not to use it. I think anytime you're using data that was collected for another purpose, though, you have to be very cautious and really spend a lot of time thinking about what was collected, how was it done in this way, and does it really overlap with what you want to use it for, because there could have been things that were measured differently, how people got into the data set might have been different than you would have wanted, and there's always the risk that the stuff that you really need to know to make a comparable comparison group just isn't in the data set. I mean, if it's just sort of basic county level demographics, and you're doing an intervention that really relies on understanding the food insecurity status of someone to then offer treatment, then the information may just not be there to be able to make reasonable comparisons. However, if it is, then there's no reason you can't use it. So I think it really will be on a case by case basis, and that applies at any level of socioeconomic diversity. If the information is in there, then great. If it isn't, then it's not going to work, and it's probably worth investing some time into figuring out whether the data set really has the information that you need.
Thank you. And I have another question for Danielle on specifically the study that you did at Children's Hospital of Philadelphia. One of our participants really wants to know, did you recruit any non-English speakers for the food insecurity study? And then if you didn't, how did you match and or control for that particular population?
Absolutely. So we, for this particular study, did not recruit non-English speaking participants. And the reason for that, we were originally going to, but we in looking at our patient data ahead of time, found that there was only 2% of our patient population who are non-English speaking. So for the purposes of this study, our sample population was still very comparable to the remainder of our patient population in the emergency department. But absolutely, that is a limitation of our study design, is that we were not able to engage those regardless of how small of a subset of our patient population there were who are not English speaking.
Thank you. Another question that a participant posed, and I really I'm glad he asked this, was how can we evaluate or really assess an empowerment model like community health workers and training community members in advocacy and that sort of intervention, as opposed to some of these other interventions that have more clinical and measurable outcomes like A1C, hemoglobin, etc.
So I think for all these things, the heart of, I think, sort of the scientific endeavor, which by no means is sort of the only way to generate knowledge, is measurement. And so I think what it really comes down to is, do you think you can measure whatever the right outcome of the study is? It's completely true that a health outcome or a biomarker like hemoglobin A1C or a utilization outcome is not the right outcome for every study. But there's probably something in your mind that you think the intervention is doing, and whether that's something like empowerment or patient activation or community cohesion or any of these things. If there's something in your mind that you think your intervention is causing, then I think you can at least sit down as a team and think about, well, what is the right way to measure that? What should we see change if the intervention is doing what we think it's doing? And there are, for sort of what are sometimes called psychometric type things, there's a wide range of various instruments to do that. Some come out of the healthcare field, others come out of psychology or sociology or anthropology. And so, I think for almost any outcome, you probably can find some area that people have looked at and said, all right, how do we determine that a community is more cohesive, or that there's more political voice in a given neighborhood or something like that? And so it'll be a question of finding the right expertise for your particular thing. But in general, I do think it is possible to sort of match up a measurement to whatever the concept is that you think your intervention is doing, but it may just require some legwork and finding the right study team who really knows how to operationalize what it is.
Great. Well, add on. Oh, I'm so sorry.
Oh, no. Please go ahead. Please go ahead.
One thing is that for that specific question regarding community health workers, I would just throw out as a resource the community health worker program at Penn. It's called Impact, but available at chw.upenn.edu. And the team over there has done a really nice job at evaluating community health worker specific programs.
Thank you. Thank you to you both. And it looks like we are just coming up at the 3 p.m. Eastern hour. I just want to extend another huge thank you to both of our panelists, Seth and Danielle, as well as Caroline from SIREN, the Social Interventions Research and Evaluation Network. Seth and Danielle, we have a ton of questions that our audience really want answered, so I will be sure to send you those and the contact information if you want to answer those questions, as well as if you have, either of you have any literature that you suggest to send to our participants for their further knowledge and education in this space, I would welcome that. Participants, a recording of this webinar will be available on the Root Cause Coalition's website, and we'll be sending out a follow-up email once that recording is live. Thank you all so much for taking the time to join this how-to webinar. I hope you all have a wonderful rest of your day.